We're here looking at the Cook HemoSpray device. This is a hemostatic spray, endoscopic spray that we use that we can use for acute GI bleeding. It's something that's been very useful to us, especially in bleeds that are very difficult to control using standard methods, and also in tumor bleeds. There are other settings. I think those are the most common where we've been using this with a lot of success. The device here we're using has a 7 French catheter that can go through a standard endoscope. It's also available in a 10 French catheter, which can go through a therapeutic channel. So essentially what we do here is we have our catheter and we have our device here, which is powered with a CO2 cartridge. We have our little red handle here that we twist to activate it. Right now we have the stopcock on the on position, so whenever we need to, our technician can go ahead and start spraying. One of the pitfalls here is that these catheters sometimes can get clogged if there's fluid, so that's something we want to be cognizant of. What we've been doing, and there are definitely other methods where you can use a stopcock and different methods, but we just put our finger on top of this catheter as we pass it down. That tends to keep the fluid out of it. Some people use a syringe with air, a 60 cc syringe, and kind of put pressure on it, gentle pressure, as they pass it down. Once you have it down into the stomach, we want to really kind of avoid suctioning fluid to avoid that clogging and keep the catheter tip out of pools of blood. And at this point, we really just kind of aim and shoot, and we aim at our bleeder. We don't have to be very accurate because it sprays really broadly, and we can go ahead and fire here. Okay. Yeah, so we're going to go ahead and just... Yeah.
I like that aim and shoot. I'm going to steal
Yeah,
that
you get a nice, it looks like a nice, beautiful snow globe at Christmas. We could stop there. Yeah.
All right, that is...
And so, you may lose a little bit of visualization here. You can clear your lens. And really just patience is important here, just kind of waiting for the snow to settle. And then we can generally get a good view there. And most of the time we see that, close to 90% of the time, this is really stopping acute bleed successful. And generally works very well for that.
For management of GI bleed, where in your algorithm do you like to use it? Let's say, is it after you took the glow probe and burned it and it's still bleeding? Or sometimes as a first step, maybe?
Great question, and that's I think what our fellows are often asking, where does this fit in with the protocol? Because we've really taught that we should be using dual therapy for our GI bleeds, especially our upper GI bleeds. And I think where we're seeing this really fits in especially is when they're failing standard therapy, right? Then we can bring in this device and at least get control of that bleed. When we have massive bleeding and we really feel uncomfortable in the middle of the night, trying to control that bleed with standard methods, this can be really,
position.
Yeah, exactly. Difficult position if you can't get near it. Or for example, if you've touched it with a clip or a cautery probe and made it worse, right? In those situations, it's very useful. For tumor bleeds, I think it's probably the only method we have, and actually seems, based on the data, seems to be working pretty well for tumor bleeds with not a lot of rebleeding. We've had good success with tumor bleeds, and we're also seeing an area where patients who are at very low risk of rebleeding, you may want to consider using this for even as monotherapy. So, sometimes the ICU, we see these cardiac patients with diffuse bleeding,
right.
Where there isn't really a pinpoint target for therapy. So this can be really useful.
For some reason this year we had several patients with diffuse various hematological malignancies.
Yeah.
Then they came with very devastating, was just this diffuse
bleeding.
From everywhere you breathe on the stomach, they bleed.
Exactly.
And we used HemoSpray very successfully in that to stop it.
I agree. Yeah. I mean, there's other places you can use it. Out if you're in a, let's say, rural setting and you don't have a lot of backup, and you need to just get a bleed under control. You can get a bleed under control and get that patient to a tertiary center, to someone like one of you guys to get control of that bleed. And so that's another great use for HemoSpray.
How about in the rectum? APC versus this versus RFA versus what do you prefer?
Yeah, good question.
For proctitis.
Yeah, for proctitis. I mean, I think if you're in a setting where there's kind of a lot of blood and you just want to sort of get diffuse bleeding under control, it's very reasonable to use something like this. Obviously, this isn't going to do any ablation. So later you want to bring that patient back and try to use APC or RFA or whatever method you want to try to ablate and get rid of that tissue. But yeah, I think in general for diffuse bleeding, it's a useful tool where we don't have a lot of other. Sometimes if you use APC when you have diffuse bleeding, it just gets messy and a lot of coagulation, and sometimes you get more bleeding. Exactly. So it's like you're kind of, it's like a weird cycle. So this is very useful, I think, in those situations.
What about post-sphincterotomy bleeds?
Yeah, good question. I mean, there's not really a lot of data. Anecdotally, I'll tell you, we have used it before. I like to have stents in, if I'm going to spray on the sphincterotomy site, but I have had a situation where I sprayed an EMR site that was oozing in the duodenum and it got onto the papilla. The patient was fine. We haven't really seen pancreatitis or cholangitis using this. So yes, it can be used in a post-sphincterotomy bleed if you're having difficulty. We all know it's kind of difficult to clip with a duodenoscope, right? Sometimes they don't work properly. So it can be used in a post-sphincterotomy bleed, but again, personally, I prefer to have stents in there if I'm going to spray on there. Yeah.
So if you have a tumor that's not acutely bleeding, it's oozing, how much is enough? How do you know when is enough?
Are you
Is it
using
too little? Is it too much?
Yeah, good question. I don't think anyone really knows. We usually just usually kind of go at it and white it out until we see that the oozing is stopped. Watch it for a little bit, and if that's if it stops, then we finish the procedure and we see how the patient does. And then at that point, you want to, if there's some sort of definitive therapy, it gives you time so the patient can get to surgery or radiation therapy. Yeah.
That's perfect. Thank you so much.
Thank you.